Hello, my name is Ana Fernandez, and I'm here with Henry Morales, and we're going to be talking about cerebral palsy. So, what is cerebral palsy? Cerebral meaning brain, and palsy meaning weak is a collection of conditions that impact a person's capacity to move, their equilibrium, and their ability to maintain posture. Uh, Other issues that may present with people with cerebral palsy will be intellectual disability, seizures, visions, hearing problems, speech problems, alteration in the spine, and joint issues. Now, what causes the cerebral palsy? Well, basically, it would be damage or abnormal development in the areas of the brain that control movement. It can occur prior, during, or immediately after birth, as well as during the first several years of life. The causes of cerebral palsy would be like white matter of the brain has been damaged. Any disruption to the white matter can cause movement or controlling signals between the brain and the body to be disrupted. Um, Efficiency of oxygen to the brain. If the brain is deprived of oxygen for an extended period of time, the brain is going to be harmed. Now, also, if the brain starts to bleed, a stroke can happen to the fetus, and this is a common cause of bleeding in the brain. Um, Brain growth that is abnormal is another cause. So the propagation of brain messages is affected by that type of abnormality when the brain grows abnormally. The clinical presentation would be alteration of muscle tone. It's going to have the patient will have a delay of postural reactions. It's going to have delay of motor development, persistence of primitive reflex, and abnormal motor performance. Now, continuing with the clinical presentation, it has been found that it is common due to increased intracranial pressure that the child might present with a microcephalus, meaning that the infant head is smaller than usual, or it could present with a hydrocephalus, meaning that there's a buildup of fluid in the brain. Now, the gross motor function classification system. So this is a system that was created because there was a need to have a standard measure of the severity of the cerebral palsy. Here in this picture, we can have an idea of how the levels are going to look like visually and how they're going to present depending on the gravity of the cerebral palsy. As you can see, in this test, there are 5 levels. The Gross Motor Function Classification System Level 1, or GMFCS Level 1. In this first level, what we're going to see is that children take walks at home. They are able to take walks outside, going to school, or in their neighborhood. They climb stairs without using a guardrail. They have gross motor ability such as jogging, velocity, stability, and coordination are restricted. And now in level 2, we're going to find that here children have the ability to walk and ascend a stair while holding into the railing. They're going to have trouble walking large distances. They will have trouble with balance and on uneven ground, lifts, busy settings, and enclosed spaces. At level 3, what we're going to find is that children with the aid of handheld, children can walk with the aid of a handheld mobility device. As you can see in this picture here, on the right, the left one. Without monitoring or support, they can ascend steps while hanging to the handrail. And when traveling lengthy distances, children use wheeled mobility and might self-propel for lesser ranges. For the level 4, what we're going to find is that children here are going to need help or physical help from a person or power mobility, like you see here in the picture. I'm gonna use this kind of device that is propelled with electricity. We can walk. They can walk, sorry, small distances without physical help at home, but use power mobility or body support walker. Now, at level 5, what we're going to see is that the children's capacity to sustain anti-gravity um, posture, as well as coordinated leg and arm movement, is restricted. And now I'm going to leave you with Henry that will keep talking to you guys about the types of cerebral palsy, but just to give you a small resume of what they are the spastic cerebral palsy, the kinetic cerebral palsy, ataxic cerebral palsy, hypotonic cerebral palsy, and we're also going to find a mixed cerebral palsy.
Hello guys, how are you? So my partner Alan was explaining a little bit about cerebral palsy and its different effects and different ways it can affect a child or a pediatric patient. So I'm going to go ahead and take over and explain a little bit about the different types of cerebral palsy. So the most common form of cerebral palsy is something called spastic cerebral palsy, and that's pretty much where the patient presents with an affected limb. Usually it's just one limb, known as monoplegia. So in this case, we're spastic cerebral palsy patients. They deal with a lot of tight muscles, obviously. They deal with hypertonicity and stiffness, which affects their range of motion and their functional abilities, and their ability to move in general. Okay, so unfortunately, this being the most common condition, on top of just being one limb, and also known as monoplegia, they also suffer from hemiplegia. Muscles of spastic CP patients are really tight, depending on whether it's monoplegia, diplegia, or quadriplegia, or hemiplegia. They can all present in any way, depending on the patient and the case. At the end of the day, they're all going to limit the patient's functionality and movement. And when patients have diplegia in the legs, in the lower extremities, they're going to present with something called the scissoring gait, which just means that they're going to have tight muscles in their legs and hips, which is going to cause their legs to go ahead and cross over when they try to walk. And it's a potential tripping hazard, of course, as you could tell, as these patients are going to be stumbling and pretty much walking over their legs as they try to ambulate. There's also spastic hemiplegia. It usually occurs on one side of the body. Usually the upper extremity is affected more than the lower in this case. There's also spastic quadriplegia. This is the most severe form of CP, and so this is the most severe form of the most common form of CP. So with spastic quadriplegia, the patient has the muscles of the lower extremities, upper extremities, tongue and mouth affected, as well as the trunk. So you can see why it's definitely the most severe form of cerebral palsy. In this case, they're going to present with loss of control of body movements and dysmetria, just like the hemiplegia or the diplegia, but the problem is that most of their body is affected, so it's going to be very difficult for this type of patient to go ahead and function and go throughout their daily activities. So we also have ataxic cerebral palsy, which is going to cause a lot of balance problems for our patients. It's going to cause for a loss of control of body movements and dysmetria. So ataxic is going to cause a gait deviation more than the other ones. Okay. We also have dyskinetic cerebral palsy. It's going to cause pretty much a lot of involuntary movements when they have a cerebral palsy that affects the basal ganglia. Okay. The patient also may present with lessened muscle tone and hypotonia when they have the dyskinetic cerebral palsy, since it is affecting the basal ganglia, like we said. We also have hypotonic cerebral palsy. So hypotonic cerebral palsy is just another form of cerebral palsy where the main problem is going to be hypotonia throughout the patient. It could be in one limb or both or all four. But yeah, hypotonic cerebral palsy patients are going to deal with a lot of hypotonicity and weakness, and they're going to be obviously hypermobile, and they could use a lot of strengthening to get them to a functional level. Okay. There's also one final version known as mixed cerebral palsy, This one is a little difficult and tricky to deal with because cerebral palsy is going to have injured a lot of parts of the brain, different parts of the brain. So it's not localized in just one lobe. It's going to cross over to different lobes of the brain, which is going to cause a lot of symptoms and a lot of different types of disorders. So these are usually very tricky cases to deal with, although not as common, but do require a lot of medical care and attention and interdisciplinary work with the medical teams. So the purpose of appropriate pediatric tools is to determine if there's any impairments and to see what the functional goal is here, to see where we want to get to our patient to, and what the problem currently is, how bad is it, where is it, etc. Movement assessment in infant, also known as MIA, has been found to help predict cerebral palsy in pediatric patients. So MIA, movement assistant in infants, is something that we use to go ahead and get a head start on knowing what exactly the pediatric patient is going through. So it's also a tool that can not only be used for cerebral palsy, but just for infants at risk of the developmental delay in general. So that in combination with another tool that we use, the Bale scales of infant development, that gives us a really good idea of what this infant or toddler is going through and the type of problems that they're going to experience if there are any to begin with. So these pediatric tools, to say the least, have gone a long way in helping us as therapists evaluate, recognize, and intervene appropriately, and it has improved a lot the results in these young patients. Okay, so the way we approach dealing with infants with cerebral palsy, regardless of the type of cerebral palsy they have, is according to the Neurodevelopmental Treatment Association instructor group. What we're pretty much going to do first off is collect data. So get the date of birth and the date of assessment, understand everything as far as the dates and how long patients have been dealing with things, get all the information we need so we can properly assess and treat this patient. The next thing we're going to do is worry about examining the gross motor control, their fine motor control, and their sensory information. So we have to see how their deep sensation is, their light sensation, their cortical sensations, how's their gross motor control, and their fine motor control. Assessing all these things along with the information we gathered is going to give us a better idea of how we can best treat this patient. Okay. So what we're going to do after that is we're going to evaluate areas of concern, functional limitations, barrier to participations. So we're going to see how exactly is this pediatric patient being affected, and what is it affecting them in. And we're going to do our best to form a plan of care where we specify the anticipated goals and outcomes for both long-term and short-term, so we can get this infant and pediatric patient towards, the type of functional lifestyle that he or she was bound to have anyways. So we try our best to go ahead and have the plan of care reflect something that's very functional and something that would make the patient, and in this case the parents also, considering how young the patient is, make the family overall extremely happy. Okay, something important to note is, as far as treatment goes, not all the following therapies have been proven to be effective for people that suffer from cerebral palsy. So something that has worked and usually works in most cases is physical therapy, more specifically workouts and activities that can help you maintain or increase your muscular strength, stability, and mobility. So this is something that anyone and everyone should and can always work on. So this has been proven to be something that does help, and does help in returning our patients, even infants, to a more functional level. Because at the end of the day, everyone needs strong muscles to be able to be stable and to be able to be mobile and to be able to, have skill and conduct the activities we like to. So we use orthotic devices to help our pediatric patients with mobility and balance. We use a lot of lower extremity orthotic devices, braces and splints, and just, your basics, like cam boots for pediatrics and stuff like that. We also do have wheelchairs, rolling walkers, and motorized scooters, and some of the other equipment that we have for adult patients are available for pediatric patients as well. So there really is a lot of options as far as treating a pediatric patient, and what's the best way we can make their life most functional and the safest and also the most independent. So with that being said, medications, we do use medications over the counter. Well, not us, but they are prescribed to the patient to soften stiffer hyperactive muscles and minimize aberrant motions. So we pretty much just try to get that muscle coordination, minimize those hyperactive muscles, get everything as smooth as possible so this patient could contribute to physical therapy and ultimately get back to a more functional and more relaxed tone and overall increase the quality of life. In some severe cases, all these things may not be enough, and surgery could be something recommended to the family by the physicians. So, with that being said, that's pretty much a baseline of everything. So, just to review, we have spastic cerebral palsy, where 75% of children with cerebral palsy have this condition. That's where they have tight muscles, and those tight muscles could present in one limb, two limbs, one side of the body, or all four limbs. Like I said, that is most common. We have dyskinetic cerebral palsy, which is the injury to the basal ganglia. This is going to cause dyskinetic cerebral palsy. Dyskinetic cerebral palsy, just as a refresher, just means that there's going to be a lot of involuntary movements in our patient. Balance, so let's see, ataxic cerebral palsy. Balance is the biggest problem for these patients as they're going to walk with a scissoring gait. This is going to be obviously a huge fall hazard, a huge safety hazard, and something that should be addressed with physical therapy as soon as possible. One more, we have hypotonic CP. Hypotonic cerebral palsy just refers to basically the fact that there is a large lack of muscle tone. And lastly, we have mixed cerebral palsy, which is a mix of all of these, sometimes all of them, sometimes some of them. And this is because of diverse injuries to the brain, so more than one lobe, more than one part is being affected. When you add all these things together, it creates a very complex case and a very difficult form of cerebral palsy to keep under control. But we still have our interventions to try our best and to get that patient to a functional and independent level. So with all that being said, that hopefully gives you guys a better idea of cerebral palsy, the different types of cerebral palsy, the different ways that we can help, the different ways other medical professionals can help, and yeah, and the different types of pediatric tools that we use to assess and get ahead of the curve on this. All that combined with everything my partner Alan explained should give you a pretty good idea of what is cerebral palsy, how does it present, how do we treat it, why does it affect the patients the way it does, and how do we assess it, and how do we recognize it, and how can we do our best to help.